Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 271 of our pharmacotherapy series, which majors in skin and soft tissue infections. The first question reads, TMC is a 22-year-old college football player who presents to the emergency department with a 3 to 4 day history of pain in his left thigh. On examination, he has a swollen, erythematous, and purulent 2 times 3 cm abscess in the inner left thigh. The area is warm and tender to the touch. TMC is afebrile with no signs of lymphangitis. What tests are needed to confirm the diagnosis? In patients with abscesses, large furuncles, that is superficial skin abscess, and carbuncles, that is clusters of furuncles, gram stain and culture of pus is recommended. Though, typically cases may be adequately treated without further testing. TMC has risk factors for community-acquired MRSA, being a competitive athlete. If community-acquired MRSA is identified, infection control measures should be implemented to prevent outbreak. In febrile patients, blood cultures should be drawn before antibiotics are started to maximize the ability to isolate the pathogen. The next question reads, are the suspected organisms similar to those found in other patients with cellulitis? Abscess, furuncles, and carbuncles are most commonly caused by staphylococci, predominantly Staphylococcus aureus. Abscesses may also be polymicrobial. For patients who are IV drug abusers and present with abscess or cellulitis, the infecting bacteria are similar to those found in normal hosts. Intravenous drug use is also a risk factor for infection with community-acquired MRSA and should be particularly considered if the patient has had recurrent infections or has failed to respond to MSSA-directed antibiotic therapy. Although Staphylococcus epidermidis, gram-negative organisms, including Pseudomonas aeruginosa, and anaerobes are rarely pathogens, they may be present and should be considered in patients who do not respond to initial therapy. The next question reads, what is the appropriate empiric therapy? Antibiotic therapy is often not required. Incision and drainage should be performed for all abscesses, large furuncles, and carbuncles. Antibiotics may be considered as adjunct to incision and drainage when systemic inflammatory response syndrome is present, but has not been shown to improve cure rates in patients with cutaneous abscess. Antibiotic therapy should be directed toward community-acquired MRSA and based on severity of infection. Mild to moderate infection can be adequately treated with doxycycline or sulfamethoxazole, trimethoprim, whereas more severe disease should be empirically treated with vancomycin, daptomycin, linezolid, telavancin, or ceftaroline. If treatment does not result in some resolution of inflammation within 48 hours, antimicrobial coverage should be expanded to cover gram-negative organisms and resistant streptococci. The next question reads, DOD, a 70-year-old man, presents to the emergency department with a red, swollen face. He describes the area as a swollen red spot that has appeared during the past 2 days. He also describes feeling unwell for the previous 3 days and having a fever. On examination, DOD has a bright red, shiny, edematous lesion on his right cheek that is 0.4 cm wide. It is a continuous lesion with a clearly demarcated border. What antibiotic therapy should be initiated for DOD? Erysipelas will respond promptly to antibiotics with activity against group A streptococci. Oral penicillin V 250 to 500 mg every 6 hours, and for severe cases and parenteral penicillin G, dosed at 2 to 4 million units IV every 6 hours generally reduce the systemic symptoms, e.g., fever or malaise, within 24 to 48 hours. However, it will take several more days for the skin lesion to resolve. If DOD's condition does not improve within 72 hours after initiation of antibiotics, he should be instructed to return for reassessment. If DOD has an allergy to penicillins, then a macrolide, clindamycin, or an oral fluoroquinolone, such as moxifloxacin, is an alternative. Ceftriaxone may also be an alternative in penicillin-allergic patients without anaphylaxis due to low, that is less than 1% cross-sensitivity risk. If the community has increased macrolide resistance to group A streptococci, these agents should not be part of empiric therapy. Antibiotic therapy should be continued for 10 days even if signs and symptoms resolve quickly to avoid a relapse, which could lead to chronic infection or scarring. The next question reads, PTU is a 67-year-old man with diabetes mellitus presenting to his general practitioner for a routine checkup and has no specific complaints. PTU has a 15-year history of poorly controlled type 2 diabetes mellitus and a 3-year history of recurrent foot ulcers. On examination, the physician observes that an ulcer on the underside of the foot, which had previously healed over, is open and inflamed. Purulent fluid can be expressed from the wound. PTU reports no pain around the area and was unaware that the ulcer had worsened. He is currently febrile, and physical examination reveals mild lymphadenopathy and elevated white blood cell count. Does PTU have an active infection, and is antibiotic therapy required? All open wounds, in diabetic and non-diabetic patients, will become colonized with bacteria, but only infected wounds should be treated with antibiotic therapy. Often it is difficult to determine whether an open wound is infected, but signs and symptoms, e.g., purulent drainage, erythema, pain, and swelling around the area, are suggestive of infection. Based on his symptoms, PTU has an infection that requires treatment. The next question reads, what treatment should PTU receive? Prior to initiating antibiotic therapy, the presence of a clinically infected wound must first be confirmed, as often diabetic wounds may not be infected and thus do not require antimicrobial therapy. When determining appropriate antibiotic therapy for infected wounds, clinicians must consider the severity of infection, mild versus moderate to severe, whether the patient has risk factors for MRSA or Pseudomonas aeruginosa, or whether the patient has received any antibiotics within the past month. Mild diabetic foot infections should not be treated with topical antibiotic preparations because the evidence of efficacy is limited. The preparations do not allow sufficient penetration of antibiotic into the tissues. Many preparations are detrimental to wound healing. Mild infections can be treated empirically in a similar way to other soft tissue infections because these are commonly caused by aerobic gram-positive cocci. A penicillinase-resistant penicillin, e.g., dicloxacillin or cephalexin, will be effective in most cases. The choice between these agents should be based on tolerability and cost. Alternative agents include clindamycin, amoxicillin, clavulanate, or levofloxacin. If anaerobes are suspected based on malodorous aroma, if the infection is severe or long-standing or has recently been treated with antibiotics, clindamycin or amoxicillin, clavulanate monotherapy can be used, or metronidazole can be added to the regimen. If metronidazole is selected, concurrent use of an antibiotic with good activity against aerobic pathogens is required, because metronidazole has no activity against aerobic bacteria. In patients with significant vascular compromise, crepitus, or gangrene, a radiograph should be taken to identify any bone involvement suggestive of osteomyelitis. For treatment of moderate to severe infections, oral or parenteral antibiotics, IV recommended for severe, may be used depending on signs and symptoms and should be selected based on suspected organisms. For Staphylococci, Streptococci, and Enterobacteriaceae, therapeutic options include levofloxacin, cefoxitin, ceftriaxone, ampicillin, sulbactam, moxifloxacin, ertapenem, and imipenem, cilastatin, or tigecycline. Levofloxacin and ceftriaxone have no anaerobic coverage, thus, clindamycin or metronidazole should be added if anaerobes are suspected, in the case of ischemic or necrotic wounds. It is important to consider that clindamycin may be more likely to cause Clostridioides difficile-associated diarrhea. Other considerations in antibiotic selection should include MRSA or Pseudomonas aeruginosa when risk factors are present. Infections due to MRSA can be treated with vancomycin, daptomycin, or linezolid. Newer antibiotics, including dalbavancin, telavancin, eretavancin, and ceftaroline, have activity against MRSA skin and soft tissue infections, but there is a lack of efficacy data in diabetic foot infections. Infections due to Pseudomonas aeruginosa may be more common in patients in areas with high local prevalence, warmer climates, and frequent exposure of foot to water, and can be treated with piperacillin, tazobactam. Other antibiotics with activity against Pseudomonas aeruginosa include cefepime, ceftazidime, aztreonam, imipenem, cilastatin, meropenem, or doripenem. Aminoglycosides are associated with serious toxicity if used for an extended period and should probably be avoided in diabetic patients. Because PTU is an elderly diabetic patient with systemic signs and symptoms of infection, moderate to severe, empiric therapy with cefoxitin, ceftriaxone, ampicillin, sulbactam, levofloxacin, moxifloxacin, or ertapenem would be appropriate because he does not have risk factors for MRSA or Pseudomonas aeruginosa infection. The next question reads, despite aggressive antibiotic therapy and debridement, PTU's infection spreads and an amputation is required. How long should antibiotics be prescribed for PTU after surgery? Antibiotics may be continued until signs and symptoms of infection have resolved. Typical treatment duration is 1 to 2 weeks, however, longer treatment duration 2 to 4 weeks may be necessary in patients with moderate to severe infections or in patients with infections that are slow to resolve. Oral therapy should be considered once the patient has clinically improved. Treatment can be stopped even if the underlying ulcer has not completely healed. The best option for uncontrollable, life-threatening infections often is amputation to remove the infected area. Once the infected area has been removed, antibiotic therapy should be continued for 2 to 5 days. The next question reads, what measures could have been taken to prevent this complication in PTU? Many of the foot problems associated with diabetes can be prevented with proper foot care, and these preventive measures must be emphasized. Diabetic patients with neuropathies or those who are elderly should carefully examine their feet every 1 to 2 days. The next question reads, MMT, a 45-year-old alcoholic homeless man, presents to the emergency department with a broken nose and facial lacerations which he received after a fight outside one of the local taverns. On examination, in addition to the facial wounds, an area of severe inflammation, erythema, and necrosis is evident on his left calf. The area is very painful, crepitation is felt over the area, and a purulent discharge is present. MMT states he believes the infection is because of a knife wound he experienced approximately 1 week ago. What antibacterial treatment should be provided? In addition to setting the broken nose and suturing the facial lacerations, the clinician should evaluate the infection on MMT's calf. A gram stain and culture of the purulent discharge should take place before initiating antimicrobial therapy. Because crepitus is present, the area should be incised, and a specimen of the infected tissue should be obtained for gram stain and culture. Because the presence of crepitus may suggest a necrotizing infection, an immediate surgical consultation will be required for MMT pending the surgical evaluation. Fluid resuscitation and IV antibiotics should be initiated. Gas in the tissues could be caused by many organisms, and empiric, broad-spectrum antibiotic therapy with coverage against gram-positive organisms, the Enterobacteriaceae, and Bacteroides fragilis should be started. Initial therapy with piperacillin, tazobactam, ampicillin, sulbactam, or carbapenem plus anti-MRSA antibiotic vancomycin, daptomycin, or linezolid should be used. Clindamycin is often added for suspicion of group A streptococci, not for its antibacterial effects but because it inhibits protein synthesis, which may reduce toxin expression by the bacteria, and cytokine response by the host. Alternative options include ceftriaxone plus metronidazole, or a fluoroquinolone plus metronidazole. If a gram stain of the infected tissue clearly shows the predominance of gram-positive cocci, consideration of narrowing the spectrum of antibiotic therapy is appropriate. Flesh-eating disease is usually a necrotizing fasciitis caused by virulent strains of group A streptococci. High-dose penicillin G, 3 million units every 4 hours plus clindamycin, 900 mg IV every 8 hours, are the drugs of choice for this condition, as well as for gas clostridial myonecrosis. Potential adjunctive therapy for streptococcal necrotizing skin infections includes IV immunoglobulin G (IVIG), dosed at 2 grams per kilogram as a single dose or 0.4 grams per kilogram daily for 2 days. Alternative dosage regimens have included 1 gram per kilogram on day 1 with 0.5 grams per kilogram on days 2 and 3. No clinical trials have proven the definitive benefit of IVIG, and the optimal dose, if used, is unknown. If it truly provides benefit, IVIG is thought to work by binding to the superantigens released by the streptococcal bacteria that are involved in the systemic effects of the infection. The next question reads, PJP, an 18-year-old boy, presents to the emergency department 3 hours after being bitten on the leg by a neighbor's dog. He has a laceration, 14 centimeters long, on his medial calf. 4 distinct puncture marks, suggestive of teeth marks, also are present on the calf. There is no suggestion of bone injury. PJP was healthy before the attack and has no chronic illness. Should PJP receive any treatment other than suturing of his laceration? The standard of care for all bites involves wound irrigation and decontamination of the wound. PJP's wound should be evaluated for deep tissue injury, devascularization of any tissue, and bone injury. Loose suturing or closure with adhesive strips is appropriate for lacerations after irrigation. Although the safety of closure of bite wounds has been debated, a good therapeutic response has been obtained after the closure of wounds. The next question reads, because PJP has several punctures that are difficult to irrigate, he is a candidate for antibiotic therapy. Which antibiotic or antibiotics should he receive? The need for antibiotics is controversial and guided by wound severity and patient immunocompetency. The patient should receive a course of antibiotics if the wound involves the hand or is near joints, if it involves deep punctures or is difficult to irrigate, if the patient is immunocompromised, e.g., in the case of diabetes, or splenectomy, or if the wound is not well perfused. Antibiotics are not required for dog bites in which no deep tissue injury is present and the wound can be well irrigated, particularly if the wound is on the lower extremities in healthy adults or children. The selection of the appropriate antibiotic is based on the most likely pathogens from the specific animal bite. Although Pasteurella multocida often is considered the primary pathogen of dog bites, antibiotic coverage also must address the other common pathogens. Monotherapy with amoxicillin clavulanate 875/125 mg orally every 12 hours is recommended. Alternative options include second-generation cephalosporins, e.g., cefuroxime, plus an agent with anaerobic coverage, clindamycin or metronidazole. If the patient is allergic to penicillin, doxycycline, moxifloxacin, or carbapenem provides adequate coverage. In all cases, patients should be instructed to watch for improvement. If the wound does not heal or it worsens within 48 hours, the patient needs to be re-evaluated. Antibiotic treatment should not extend beyond 5 days unless signs of an infection remain. If the patient presents with an established infection, parenteral therapy is warranted if the infection is over a joint, has lymphatic spread, or involves the hand or head. Parenteral therapy should be continued until the infection has resolved, and therapy should then be continued with oral antibiotics for at least 7 days or until all clinical signs of the infection have resolved. Prophylaxis for rabies is required only if the animal is from an area with endemic rabies or if the bite was the result of an unprovoked attack by a wild animal. The local health board should be contacted to determine the recent rabies risk in the area. If PJP has not received a tetanus toxoid booster within the past 5 years, a booster should be administered. If PJP has never been immunized for tetanus, tetanus immune globulin should be administered in addition to the tetanus toxoid. The final question reads, CSK, a 40-year-old man, presents with a sore arm 24 hours after receiving a bite to his left forearm by his neighbor in a discussion over property boundaries. CSK was previously healthy and has no chronic diseases. A 6x8 cm area of his left forearm is swollen and erythematous, and includes several distinct puncture marks consistent with a human bite. No joint deformity or bone abnormality is detected on clinical examination. How should CSK be treated? Treating a human bite is similar to any other laceration, including cleansing, irrigating, exploring, debriding, draining, excising, and suturing, as required. All human bites should be cleansed as soon as possible, and any lacerations or punctures irrigated copiously. Surgical exploration with debridement, drainage, or excision should be undertaken if deeper tissues may have been injured or if pus collection could have occurred. With evidence of pus accumulation in his wound, the area should be explored and drained. CSK also should receive systemic antibiotic therapy to eradicate potential infecting organisms. If the wound is severe, i.e., involves subcutaneous tissues, a joint, or a large area, or if the patient is unlikely to be compliant with oral antibiotics, parenteral administration of antibiotics is required. The most common pathogens in human bites are beta-hemolytic streptococci, Staphylococcus aureus, Eikenella corrodens, Fusobacterium, Peptostreptococcus, Prevotella, and Porphyromonas species Corynebacterium subspecies. Treatment with amoxicillin, clavulanate, ampicillin, sulbactam, or ertapenem is appropriate. For penicillin-allergic patients, alternatives include ciprofloxacin or levofloxacin plus metronidazole or moxifloxacin alone. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 272.